In this session, I am inviting the first presenter, and then meanwhile, then Adil Nasir will take over the session. So we are having our speaker who will be presenting a topic of the changing epidemiology and prevention of HCC. So I am inviting Dr. Rosmawati Mohamed.
A very good afternoon to everyone. I'd like to thank Professor Zaigham and team for the kind introduction to speak at this conference. Liver cancer is a common cancer and is among the leading causes of cancer death globally. Now, the latest cancer data suggests that it's now the fourth most common cause of cancer-related deaths worldwide. What's even more worrying is that liver cancer cases and deaths are rapidly increasing worldwide. New cases of liver cancer have increased by a whopping 100% between 1990 and 2017. So that's double. Another study showed that 47% of the increase in liver cancer cases are due to population aging and 35% by population growth. So population aging and growth are driving the increase in liver cancer cases. Without doubt, liver cancer is also extremely deadly. The estimated age-standardized incidence are shown here in blue, and mortality rates are shown in red. Note that the number of liver cancer cases per year is similar to the number of deaths each year, underscoring the poor prognosis for liver cancer. Now, why is liver cancer so lethal? Now, up to 90% of liver cancer arise from cirrhotic livers, and cirrhosis is often not diagnosed until the time of presentation of liver cancer. HCC usually involves multiple foci, and it rapidly progresses to invade blood vessels. But what makes liver cancer particularly lethal is the fact that most are diagnosed at a late stage, as majority was not detected as part of HCC surveillance program. So what are the commonest causes of liver cancer? The underlying causes of liver cancer at the global level are shown on this slide. Now, hepatitis B accounted for the most number of liver cancer at 46%, followed by hepatitis C in 29%, alcohol in 17%, and 17% others, which include other causes of hepatitis. Now let's look at the changing epidemiology of liver cancer. Now, these are signs of modern times, with increasing number of individuals, both adults and children, with expanding waist circumference. So fatty liver, or the new term of metabolic dysfunction-associated fatty liver disease, is a major health problem and is the commonest liver disease worldwide. Now, there's now emerging data that fatty liver disease, or NASH, is rapidly becoming an even more important risk factor for liver cancer. So to illustrate this, I will show you an example from Malaysia. I will show you two studies done in UMMC. Now, this first study performed between 2006 and 2009 showed that hepatitis B is the commonest cause of liver cancer, followed by what is termed cryptogenic cirrhosis, accounting for 16% of cases. Now, a more recent study done in 2015 showed that the commonest cause of liver cancer remains to be hepatitis B, but now you can see that cryptogenic cirrhosis, and this is very likely due to NASH or fatty liver, accounts for 36% of cases, so more than double within less than 10 years. And this is actually an alarming situation. Now, the changing pattern in the cause of liver cancer is a global phenomenon, and it's mainly related to obesity. Now, there is no doubt that the global obesity statistics are getting scarier, even in Asia, and Malaysia is no exception, with the latest figures from WHO showing a 15% prevalence of obesity shown here. The prevalence of childhood obesity is equally alarming, with a tenfold increase in the last 4 decades. So nearly 1 in 5 children and adolescents are overweight or obese, and as shown here, a substantial proportion of them will end up with fatty liver disease. These studies highlighted the impact of an early start of overweight and obesity. Being overweight in late adolescence is a significant predictor of severe liver disease later in life. Now, the other study showed that high BMI in childhood increases the risk of liver cancer in adults. So when the journey from obesity to cirrhosis takes an early start, a higher number of patients will be presenting with HCC at an increasing younger age. Let's now switch gears to prevention. So first, prevention of hepatitis B related HCC. Hepatitis B vaccine is highly effective. A number of studies have shown that hepatitis B incidence is declining amongst the vaccinated cohort. Now, hepatitis B related HCC is indeed a vaccine preventable cancer. Now, this study showed the efficacy of hepatitis B vaccination in reducing primary liver cancer, with more than 80% reduction in HCC and 70% reduction in liver-related mortality over a 25-year period. For those infected with hepatitis B or hepatitis C, the best strategy to reduce HCC and other complications is early detection and linkage to care and treatment to reduce progression to cirrhosis, liver cancer, and death. Let's now look at the role of hepatitis B and hepatitis C treatment in the secondary prevention of HCC. Beneficial effect of antiviral therapy in the prevention of hepatitis B related HCC have been consistently shown in a number of studies. Now, this is a systematic review comparing HCC incidence in chronic hepatitis B patients with or without antiviral therapy. Now, there was a significant reduction in HCC incidence in favor of the antiviral treatment group. Now, the risk of HCC was reduced by nearly 80% in those on antiviral treatment. Let's now switch to hepatitis C. This meta-analysis showed that successful hepatitis C treatment can indeed reduce the risk of HCC. Now, complete clearance of hepatitis C or SVR led to a 70% reduction in HCC risk. Now, in this study, the incidence of HCC was highest in patients with cirrhosis and treatment failure. So post-treatment, those with cirrhosis or did not achieve SVR remains at risk of HCC. How do we prevent NASH-related HCC? Now, obesity and diabetes are closely related to fatty liver disease or NASH. Therefore, maximizing management of risk factors leading to NASH can lead to a potential reduction in liver cancer burden. Obesity not only increases risk of liver cancer, but also death from liver cancer. So BMI of more than 25 is associated with increased risk of primary liver cancer. Now, alarmingly, liver cancer mortality rates were 4.5-fold higher amongst men with high BMI compared to those with normal BMI. Now, obesity may also influence risk for liver cancer through increasing the risk for diabetes. Now, diabetes per se increases risk for HCC by 2.5-fold, independent of viral hepatitis or alcohol use. Now, note that HCC incidence increased with increasing duration of diabetes. Now, are there other ways of reducing HCC risk? Now, interestingly, coffee has been shown to provide protective effects against liver cancer. Now, this guideline on the management of liver cancer strongly recommend coffee drinking to reduce the risk of liver cancer in patients with chronic liver disease. Now, several studies have shown an inverse relation between coffee drinking and the risk of liver cancer. So, meta-analysis of 16 studies have shown 40% reduction in liver cancer risk amongst coffee drinkers compared to those who did not take coffee. Now, generally, the consumption of other beverages such as tea or decaffeinated coffee is not associated with reduced risk of liver cancer. Now, to conclude, there is increasing burden and death related to HCC and hepatitis worldwide. Now, hepatitis B is the commonest cause of liver cancer. Now, the changing pattern in the epidemiology of HCC is largely due to the rising prevalence of fatty liver-induced liver cancer. And lastly, attempts to reduce liver cancer should aim at prevention and control of viral hepatitis and curbing the growing epidemic of obesity, diabetes, and fatty liver disease. Thank you.
10 members in this conference.
Abbas. He is a shining star of hepatology in Pakistan and current president of Pakistan Society of Study of Liver Disease. He remained Dean Faculty of Gastroenterology from College of Physician and Surgeon Pakistan, and he's also a Governor Pakistan Chapter of American College of Gastroenterology. So he'll be talking about biomarkers in surveillance and diagnosis of HCC.
Is there any question related to the previous talk, so we can take those questions? Okay. So there is no question until asked. So we will continue with the next presentation.
Centimeter with preserved liver function and good performance status. Again, you can offer curative treatment in the form of resection or ablation or transplant. In patients with an intermediate stage, we can offer chemoembolization with improved survivor, but with the patient with advanced stage, if they have been some vascular invasion, but the preserved function is there and performance status is also good, then you may offer systemic therapy or chemotherapy. But if the patient has been presented to you very late, then you cannot offer anything to your patients, and the survival is very poor. So if the surveillance program is there, like Japanese program, which has been implemented there, and they are able to detect liver cancer at a very early stage and able to offer curative treatment. In Pakistan, where there is no surveillance program, and mostly we see patients as a referral patients, most of these patients presents very late. We can offer to them chemoembolization or chemoradiotherapy or immunotherapy or sorafenib. But many of these patients present very late, and only palliative treatment may be offered. So this is a large study which was done in about more than 15 years back, in which more than 18,000 patients were randomized to receive surveillance with alpha-fetoprotein and ultrasound every 6 months, or controlled group did not receive any surveillance. There was much higher pickup of hepatocellular cancer in the patients who are under the surveillance program, and this resulted in 37% reduction in the mortality and improved survival. This is another study from Korean cohort, and this again shows that the survivor and its effect on the early detection on the hepatocellular carcinoma and the treatment results in the better survival. So surveillance group had the better survival. So there are guidelines by different societies. AASLD says that these patients should be under surveillance every 6 months, and alpha-fetoprotein, which is the serum biomarker, is optional, while either again stresses on ultrasound every 6 months, while APASL includes alpha-fetoprotein with ultrasound. And Japanese Society of Hepatology includes alpha-fetoprotein, PIVCA, and alpha-fetoprotein L3 with ultrasound every 3 to 6 months. So there are differences in the surveillance guidelines. So can we rely on ultrasound alone? Like this has been there in AASLD guidelines. This may be true in the ideal world, but in the real world, we have a lot of problems because ultrasound is operator or instrument dependent. It's less accurate in obese patients, lacks precision in patients with severe cirrhosis. Moreover, obesity, ascites, and motion interferes with imaging, and there is difficulty to detect small, less than 2 centimeter lesions. So we have the biomarkers for surveillance early detection. As we know, alpha-fetoprotein, we have been using this biomarker. Then alpha-fetoprotein L3 or lectin-reactive alpha-fetoprotein, and this gamma-carboxyprothrombin, which is PIVCA2. There are other biomarkers which have been used and approved. Alpha-fetoprotein alone has a low sensitivity for detection of small cancers. So the sensitivity only for small cancer is 20 to 30%. Because of poor sensitivity and specificity, testing alpha-fetoprotein alone should not be used, and you have to combine this with ultrasound. What about gamma-carboxyprothrombin or PIVCA? As you can see in this graph, comparing alpha-fetoprotein with gamma-carboxyprothrombin, more HCC patients had increased PIVCA compared to alpha-fetoprotein. So about 2/3 of the alpha-fetoprotein negative patient had a positive gamma-carboxyprothrombin. And this is meta-analysis of 38 studies involving 11,000 patients. PIVCA had a higher accuracy for diagnosis of hepatocellular carcinoma with diagnostic odds ratios 23.69 and poor sensitivity and specificity 66 and 8.8%. And this is meta-analysis of 31 studies, and this again shows that the diagnostic odd ratio for PIVCA was much higher as compared to alpha-fetoprotein with better AU areas under the curve as compared to alpha-fetoprotein. Diagnostic performance of alpha-fetoprotein and PIVCA was assessed in cirrhotic patients with different etiologies. 33 patients, 388 patients were included in this study, and performance appears to differ according to the etiology. So there was progressive loss of alpha-fetoprotein performance in hepatocellular carcinoma due to hepatitis C on viral or non-viral groups, where the PIVCA maintained high AUC values than alpha-fetoprotein in all the three category groups. So PIVCA appears to be having the greater accuracy as compared to alpha-fetoprotein. Can we combine both PIVCA and alpha-fetoprotein? If we combine this PIVCA and alpha-fetoprotein, then we get better AUCs areas under the curve as compared to individual markers. So PIVCA improves the detection rate of hepatocellular carcinoma as a complement to alpha-fetoprotein and ultrasound, and this has been shown in different studies, and this is one of the studies published so far. This is meta-analysis of 27 studies from different articles, and this again shows that if we combine PIVCA with alpha-fetoprotein, then sensitivity improves a lot, and so is the specificity and DOR. So we have in market PIVCA available from two platforms. One is Abbott Architect platform. In the units in that assay is milli-arbitrary units per milliliter, and then we recently approved system is the Lexis Roche PIVCA 2, and the sensitivity of detection is comparable. But here we can see that we have units, different units, which is nanogram per milliliter. Combining the SEC biomarkers, if we combine all the three biomarkers, we are able to detect more cases, and this is evident from another study in which alpha-fetoprotein, PIVCA, and alpha-fetoprotein L3 were used. So an approach may be that you combine these three biomarkers, and develop a model. So the model has been developed. This is a Galle model, which includes gender, age, alpha-fetoprotein, alpha-fetoprotein L3, and S-gamma carboxyprothrombin. The model treats variables in their continuous form. There are no dichotomous variables, and this model has been validated extensively internally and externally. And again, this shows that the Galle scoring has a higher AUC than ultrasound for detection of HCC. And if you combine Galle scoring with ultrasound, this further improves the performance. So this performance is there even in patients with hepatocellular carcinoma related to non-alcoholic steatohepatitis. Galle scoring has been validated in different groups and in different countries, including UK, Germany, and Japan.
been given the task to talk about immunotherapy in the management of hepatocellular carcinoma. We have seen major progress in recent years, and it's an absolute pleasure to present those updated data. These are my disclosures. Immune-based therapies are actually not that new. Of course, in these days we mainly talk about PD-1 and Ctla4 inhibition, but there have been numerous attempts over the last 2 decades using vaccines, antibody approaches, or T-cell transduced with chimeric antigen receptors. These have all been demonstrated to at least show some efficacy, but in a large scale, only the checkpoint inhibitors have been tested. Initial data were generated for nivolumab and pembrolizumab, mostly in patients in second line following sorafenib treatment. It was impressive and quite exciting to see response rates. We were not used to response, objective response, but we saw in the range of 15% for both antibodies that patients did show partial or even complete response. And if they responded, they actually showed quite a long duration of response. 16.6 months, more than 9 months for pembrolizumab. Very promising data, and this stimulated us to go further. In addition, those patients who did show objective responses, again, complete or partial responses, they showed a very long overall survival. Here it's for years, and we saw in some patients dramatic responses with a complete disappearance of metastasis and so on. So very stimulating data. Initially, it was thought that, like in other tumors, PD-1 ligand expression may have a predictive quality, but this turned out in clinical analysis not to be the case. So currently, we are unable to predict who is responding to therapy. The Keynote 240, following the Keynote 224 trial, was the first where in second line in a phase 3 trial, pembrolizumab was tested against placebo. Surprisingly, unexpectedly, and disappointingly, this was a negative trial. We saw a nice separation of the curves, which was maintained over time, and we saw a difference, 10.6 for placebo, 13.9 median overall survival for pembrolizumab, but it did not reach the pre-specified level of statistical significance. Was discussed as a trial significantly negative, but clinically positive. In this setting, post hoc analysis was also performed, and one of the issues observed was that patients received to a large extent, roughly half of the patients, post-study medication, contributing to overall survival. And if you censor for those subsequent treatments, actually the hazard ratio was improved. This is post hoc and just hypothesis generating, but probably a decent explanation why this was a negative trial. The other substance, nivolumab, with these initial positive data from the CheckMate 040 trial, was tested in first line, running against sorafenib and going for superiority. Like in the Pembro trial 240, the CheckMate 459 trial did not reach statistical significance. Again, a trial where we saw a trend, certainly separation of the curves maintained, and a difference, 14.7 for sorafenib, 16.4 month for nivolumab, but it was not reaching statistical significance. So another trial where there are some clinical data supporting activity, but not in a sense of a superiority trial. And based on those data, ESMO actually withdraw its initial recommendation to use nivo in this setting. FDA, in fact, maintained their accelerated approval. Recent analysis this year demonstrated good accordance with the actual new data after longer follow-up with what has been initially observed. All these data show that there is some efficacy, but it's not sufficient, and that is asking for an improvement, and improvement may come from combination therapies. A very stimulating combination is atezolizumab, a PD-1 ligand antibody, and bevacizumab, an anti-oncogenic antibody. In the initial phase 1 trial, there were 2 arms, one for the combination and assessed for objective response, and one where the combination was compared to atezolizumab monotherapy, and that was tested for progression-free survival. The rationale is that here the combination out of an immune answer which is fostered, which is augmented, is complemented by bevacizumab, which not only is interfering with tumor vasculature, but also decreasing activity of immune suppressive cells and stimulating antigen presentation. So a complex immune modulatory component added to PD-1 ligand inhibition. In the arm A, going for objective response, there was indeed a nice and unseen high number of confirmed responses in the range of 30 to 40%, depending on who and how patients were looked on. And the duration was in fact very durable, or was long ongoing. In that setting, it was further supported that the combination was in fact adding to monotherapy with atezolizumab in the arm F, in showing a difference in progression-free survival. So we have objective response, we have progression-free survival improved in the combination, and that was a good starting point for the IMPRE-150 trial, where this combination was compared in a 2-to-1 randomized fashion to sorafenib, going for co-primary endpoints OS and PFS. I would like to point out that these patients were quite advanced. Majority had either or extrahepatic spread and macroscopic vascular invasion, so pretty advanced patients. And therefore it came the more impressive to see that both median overall survival and progression-free survival were drastically improved, in fact with very good hazard ratios, 0.58 for median overall survival, 0.59 for progression-free survival. And in fact, median overall survival was prolonged in a way which was at that time of analysis roughly 8 months of follow-up not estimable. So we have here a trial reaching its primary endpoint, and going into subgroup analysis, it was becoming clear that very consistently most of these subgroups were in fact benefiting from the atezolizumab bevacizumab combo. And not only PFS and OS were improved, but there were also objective responses. For sorafenib, 10 to 13%, for the combination, 27 to 33%, again, depending on mode of assessment. And again, a long, durable overall survival, which was, a long, durable objective response, which was not reached for the combo at the time of assessment. So in a very clear assessment, objective efficacy is given. What about the safety? When we go for the absolute number of adverse events and for those higher grade, then you see that in these two arms there were basically no differences. But if you go then into details, it's becoming apparent that the side effect profile is distinct. More diarrhea and head and foot skin reaction for sorafenib, typically resulting in a morbidity and a decreased quality of life for the patient, whereas for atezolizumab it was mostly hypertension, proteinuria. There is some diarrhea and there's some pyrexia, but overall mild. In that setting, it's not coming as a surprise that quality of life is dramatically better maintained for the combo compared to sorafenib. It took almost a year until there was a significant deterioration in quality of life in patients receiving the combo, and not much less than 4 months for sorafenib. In summary, with respect to the IMPRE-150 data, overall survival and median PFS were in a clinically meaningful way improved. And not only was this combination efficacious, it was also accompanied by a delayed deterioration of patient-reported quality of life. And therefore, we have an interesting balance out of efficacy and good tolerability. This is a turning point. We do have now the first phase 3 trial where superiority over sorafenib is demonstrated in the first trial where immunotherapy is established. This led to FDA and EMA approval, and this combination is in fact now available in more than 60 years. In addition to Imprave 150, several other combinations are coming in the next years, and it will be interesting to see who will come as a competitor. Different checkpoint inhibitors, nivolumab, PD-1, and ipilimumab, Ctla4, are combined in various concentrations or dosages. And as it turned out, in the CheckMate 040 cohort using that combination, the arm A showed the longest overall survival. Objective responses were all in the range of 30%. Based on this data, this arm A with the higher doses of ipilimumab is further followed in the CheckMate 90W trial against sorafenib. Trial 22 was assessing various combinations out of durvalumab and tremelimumab, again PD-1 ligand inhibitor and Ctla4, and that has been in a complex way pursued, demonstrating that an initial and only a single priming dose of tremelimumab plus durvalumab is resulting in the highest median overall survival data and in the best objective response data. This has been followed into the Himalaya trial, which we should see data soon, where in the end 3 arms, one is closed, are compared, and the high dose tremelimumab plus continuous dose durvalumab are investigated. Other combinations are possible, and in fact there are several trials ongoing. I will not have the time to capture them all. TKIs are combined with checkpoint inhibitors. One promising combination is lenvatinib plus pembrolizumab, initially tested and resulting in a very solid waterfall plot demonstrating a high number of patients benefiting from this combo. Initial analysis in the range of 40 to 50 objective responses, and later data assessment was confirming that this is indeed the objective response rate which seems possible, and that has resulted in the definition of the LEAP-002 trial, randomized phase 3, combining lenva plus pembro and testing against lenva plus placebo. Another combination is using atezolizumab plus cabozantinib and comparing against single agent sorafenib and cabozantinib. And just to conclude, monotherapy is maybe not over yet. We still have analysis of, for example, tislelizumab in first line as monotherapy compared against sorafenib ongoing. So, in summary, ladies and gentlemen, Mr. Chairman, immunotherapy through immune checkpoint inhibitors is likely to have a very large impact on HCC management due to these very durable and clinically relevant responses and good tolerability. PD-1 inhibitors have efficacy in a subset of patients, which we are currently unable to define upfront. We have various ways to combine checkpoint inhibitors with each other, Ctla4 and PD-1 or PD-1 ligand, or with use of tyrosine kinase inhibitors. But the only combination which currently is available is the combination of atezolizumab plus bevacizumab coming from the Imprave 150 trial with the extremely good hazard ratio of 0.58 for overall survival and 0.59 for progression-free survival. atezolizumab and bevacizumab are practice changing and are the new standard of care in first-line treatment of hepatocellular carcinoma and systemic therapy. Thank you very much for your kind interest, and I'm happy to take questions here.
Thank you, Dr. Peter Gale. It was really an exciting talk, and we're excited that we have got some very new treatments for advanced HCC. Our next talk would be managing lesions other than HCC. And to talk about this topic, we have Dr. Ashok Choudhury. He is Associate Professor in Department of Hepatology and Liver Transplant at Institute of Liver and Biliary Sciences, New Delhi. Over to you, Dr. Ashok Choudhury.
So good day, thank friends. At the outset, I thanks PSSLD for their invitation. And here I want to talk on an important and interesting area, what you can say as everybody discuss about the SCC. So here we are going to talk on don't mess with the liver lesions, manage the lesions other than SCC, particularly the intrahepatic cholangiocarcinoma, adenoma and fibrolamellar carcinoma group of patients. So I have nothing to disclose and I am going to cover on these areas. Before this, I just want to highlight the liver tumors in a nutshell. You can see the common tumors grouped as benign or malignant. The topic today is going to cover the benign tumors, that is hepatocellular adenoma, and in malignancy we are going to cover cholangiocarcinoma, intrahepatic cholangiocarcinoma and fibrolamellar SCC. So why it is considered as the MES, liver as well? But most commonly we see the lesions as the secondary or metastatic, which is the most common cause of liver as well as far as malignancy is concerned. And second most common primary liver tumor is SCC. However, the rest of the group is all comes into a huge category what we have shown before. And of this, we are going to highlight few, that is intrahepatic cholangiocarcinoma, fibrolamellar carcinoma, and hepatic cell adenoma. So just coming to cover why we are getting confused. Here I want to show you a case scenario, a 65-year person who presented with pain abdomen, and evaluation has been done. On history, he is having compensated cirrhosis, HEPS related, and SBR has been achieved more than 2 years, and has a liver as well. And when he is evaluated for this tumor, his tumor markers if AFP, C99, C is both all raised, and the CT scan is not showing classical patterns. So how to proceed? So here we want to show what are the different mimics we can get. This is a characteristic of SCC, everybody aware of that. You can see this is a lesion where you can see there is atrial phase enhancement. However, this enhancement is persistent in portal as well as the delayed phase. And similarly, another area which shows partly retention and partly washout. So this commonly differential found with SCC are intrahepatic cholangio or the hepatocholangiocarcinoma. So how to proceed for a intrahepatic cholangiocarcinoma? So intrahepatic cholangiocarcinoma till now is considered to be a poorly defined entity and less explored. However, with increasing diagnosis of this entity, there is a constantly increase in the trend of diagnosis, and has been in average 6 cases per million in most of the countries, and the trend is still showing an increase in the rate. And this tumor is considered to have a intrahepatic location and have been 3 types, that is mass forming, periductal or intraductal growth. And the risk factors for this tumor is PSC, parasitic infections, fibropolycystic liver disease, hepatolithiasis, viral infections B and C, and cirrhosis per se also increase the risk by 10-fold. So how to proceed? The most important part is to confirm the diagnosis. As you know, and most of the studies agreed, the MRI is better modality for the diagnosis characteristics of this type of tumors. FNA or biopsy is often recommended, and biomarkers like CEA, CA99 may be helpful. Then we need to know the staging of the tumors. PET-CT has been studied but has a limited role, but that is the only available modality. However, we can combine CT, MRI to the PET to get a better results. And the cancer staging for the intrahepatic cholangiocarcinoma most commonly followed is the HSS TNM staging for the treatment and planning. Before going for your action for these tumors, we need to know cirrhosis presence. If it is cirrhotic, what is the synthetic function and what is the performance status of the patients. Whether cirrhosis or neurocirrhosis, we need to know the CT volumetry in both cases. However, in a cirrhosis patient, we need to know the hepatic synthetic function commonly assessed by the ICG-15. We need to know the clinical significant portal hypertension is there or no, and also the child score code before taking a decisions. So treatments available is most commonly the resection, which is considered to be the only definitive therapy. However, it's possible in 20 to 30% of cases only. And the resection is often an aggressive. It is extended hepatectomy. We often require biliary reconstructions and also the lymphadenectomy if found during the surgery. And staging laparoscopy is needed because of this aggressive nature. However, till now, no society has recommended as a routine practice, but it is a common practice followed by most of the surgeons when they go for surgery in this type of case. However, despite having curative resection, the survival is dismal, only 32%, and these patients with margin R1 is survival is nil at 5 years. The recurrence is very high, close to 80%, and the overall survival depends upon a multitude of factors like tumor size, tumor number, lymph node involvement, vascular invasion, and the poor differentials of the tumors. However, over the time, now the survival is getting better. Previously, it considered to be the resection for a cholangiocarcinoma is inferior to SCC. However, the studies are coming up that survival is equivalent. So there is a little bit paradigm shift, and there is interest for considering resection as a treatment modality in this group of the patients. Then comes whether we can offer a liver transplant or no. In fact, the data is very limited. It is coming up. This is a study from Spain where they shows that tumor having more than 2 centimeters have a very poor survival, that is 34%, and the overall survival for fibers is only 45%. And the fiber recurrence-free survival is 18%, and it has shown the recent study published in Hepatology 16 that the survival has improved from 45 to 65% if the tumor is detected very early, that is small tumors. So similarly, you can see that 71 to 65% survival is only for the selected group, that is cholangiocarcinoma, small lesions, and they have been within the criteria for be transplanted. The cause for this poor outcome is mostly the recurrence and the metastasis. However, over the time, there is shown some improvement in the survival in this group patients. So we need to know the similarly the multifocality, perineural invasion, infiltrative nature, lymphovascular invasion, and important to highlight the hilar type of cholangiocarcinoma is very poor outcome, and neoadjuvant treatment is considered to be protective or helpful, and PSC assess if transplanted for intrahepatic cholangio have a poor outcome. So with these patients, as we discussed previously, the neoadjuvant has shown a definite survival in this group of patients, and this followed a protocol of these patients should be staged. This should be received a neoadjuvant treatment. Mostly it is the platinum-based therapies, that is gemcitabine and cisplatin or carboplatin. Then this group of patients has been followed for 6 months with repeat imaging 3 months to see the biological behaviors. If these patients are doing well, then they have a liver transplant to have a good survival. So what is the role of local regional therapy, which is most feasible because transplant facilities are limited most of times? This is a data which shows that TACE is with drugs, cisplatin, doxorubicin hemisphere, mitomycin C has showing a good survival. Among this, the cisplatin with overall survival is little better than the others. TARE has been shown with yttrium beads to have a survival up to 22 months. Microablation is very successful in this group of patients, but can be done only few cases, that is those having less than 4 to 5 centimeter, is not in near a bile duct, not on the liver surface, or not adjacent to the major vessels. Similarly, hepatic arterial infusion has been tried with various drugs like fluoxetine, dexamethasone, fluorouracil, or oxaliplatin, and the survival has been seen up to 30% with a 2-year survival close to 70%. The systemic therapy, as we discussed, as this is interestingly where this was the radioembolization to be given along with concomitant treatment with chemotherapy, that is gemcitabine plus cisplatin, and has shown a good survival at 2 years. Similarly, if we consider adjuvant chemotherapy, that is after the surgery, those having T2, T3 and T4 disease states, there is a good survival and has been encouraged to be considered. So with these options, the ESL has come up with the guidelines, and I think most of centers agreed for this. Those having a single tumor TNF stage 1 and are resectable, they should undergo curative resection along with observations. Those having TNF stage 2, having single lesion or multiple vascular invasions, usually not resectable, and may be tried for a non-curative resections to reduce the tumor burden with consideration of the adjuvant therapy. However, here I can differ a little bit that we should consider neoadjuvant therapy before considering for the resections. But the data is very much limited for resection with neoadjuvant chemotherapy. When these tumors are unresectable, then this group of patients need to be considered for the treatment depending on the disease status, that is intrahepatic or extrahepatic. Intrahepatic should be considered, as we have shown, with SIRT or the loco-regional therapy along with chemotherapy, or those having systemic disease, they should be considered for the systemic therapy with a survival very close to 1 year. So I think this is, I'm agreed for these treatment protocols, and hopefully we can follow this. Then we come to the next topic, the fibrolamellar carcinoma. So fibrolamellar carcinoma is one of the tumor which is characteristically present as a large SOL, and this is average size in 70% is having 10 centimeter above, and interestingly they are all non-cirrhotics, young females, and the age group is very early, 10 to 35 years, and AP was normal in close to 90% of cases. Now they have been shown to be present with a typical immunophenotype, PD-L1 expression is there. So that's why SCC is a typical tumor with his own ISC markers, and he's having immunologically active with PD-L1 and PD-1 expression. So when you go to treatments, resection is still considered to be a good treatment with survival close to 70%, but the recurrence in long term can happen in 1/3 to nearly all cases. However, the recurrence happen is most common in first 33 months, and those who have not recurred within 5 years are unlikely to have a recurrence. Liver transplant, there is a limited data, so only we have to find this data from the UNOS, which showed that transplant has a very successful encouraging results with the recurrence in less than 10% of the cases. Local therapy is a very limited option, particularly RFA is not considered because of the large size. TS and TE has shows limited results, and other treatments only considered as case report basis and not standardized yet. Systemic therapy, because of his having immunological phenotype, he's having a typical of histological pattern, consider the cisplatin or fluorouracil, GMX regimen, and now studies because of pedal expression coming on to immunotherapies like nivolumab alone or nivolumab along with ipilimumab, and this data are case to case basis, and this considered to be not in routine, however should be considered in patients who are advanced metastatic disease and not candidate for resection, liver transplant, and locoregional therapy is limited in this group of the patients. So this is a busy slide, however it shows how these patients behave over the time, and now data are incoming that if those patients can be treated adequately for the fibrolamellar carcinoma, they have a good survival in relation to the SCC group of the patients. So just to summarize, the fibrolamellar carcinoma needs a diagnosis. MRI is the best modality. We need a biopsy. We need a ISC staining for this group of patients. We need a immunophenotyping by PD-1 expression. Staging can be done, keeping in mind that all patients need staging. In fact, due to lymph node positive, around 70% cases, paraneoplastic syndrome is a clue for this diagnosis, and the patient profile, particularly young age, large tumor, AP normal, is a clue for this also. And till now, we consider treatment as the resection, which is the only standard treatment. Lost other things are like local therapy, transplant, chemotherapy, or immunotherapy are considered as a case-to-case selective cases. So then next we come to the hepatic adenoma. Hepatic adenoma is the common benign tumor of the liver. Its incidence is more among the male. Relationship with the OCPL has been known for long decades, but these tumors are considered to be important because of risk for the rupture or hemorrhage and the malignant transformations. How this type of tumors behave? So we need to know the three common particular types has been seen, that inflammatory with HNF1A mutation with beta-catenin activation. So those having inflammatory variants more commonly in female, in fact is considered to be the most common variant, and also in obese, those having systemic inflammatory conditions, alcohol, this group have a tumors. And importantly, you should see that this should be stained for serum amyloid A and CRP because of this preferential expression and because of the inflammatory milieu. And this group of tumors which shows the high risk for hemorrhage. Then we need to study these tumors with his staining for the HNF1 alpha mutation, because this category is exclusively for women. There is a familial history. We should think of having the maturity onset diabetes of young type 3, and often that's the hepatic adenomas. And this tumor have a typical histology of having intramural steatosis, and these are the people who are having least aggressive type. So diagnosis of HNF1 alpha in a patient hepatic adenoma makes you to be comfortable with a close monitoring till the things that happen, which is less common. The next important is group the beta-catenin, which is the least common group among these, among 15% of the cases. Unusual to the adenomas, which are more common in female, this is more common among the male. Increased among the patients who are having androgen use, those having glycogen storage disease or polyposis coli disease. Their clinical resemblance in histology grossly mimic to the SCC. That is why you need to study about their nuclear beta-catenin expression and also glutamine synthetase expression. So these two are needed for the diagnosis, and this diagnosis is very much essential because these are the groups which are having at the high risk of having a malignancy. So then important things we should think of the hepatic adenomatosis. It is the presence of 10 or more. Now studies have coming up that we should consider 4, and this is all basis of a consensus. It constitutes about 1/3 of the cases. The hepatic adenosis is more common among the genetic groups, among the obesity, and those having a vascular malformation, particularly awareness malformations. And interestingly, this is not related to OCP, and these have not having any major risk for the rupture. It has been said that larger one can be resected to prevent the development of SCC. LTT liver transplant can be option, however is less commonly preferred. So this is, can you see the imaging? There is various stages of tumors are there, and one has shown the malignant transformation here. So these are the various stages. You can get a malignant transformation in future in the large one. Then the important threatening complication is the hemorrhage. It happens in 20 to 40% of the cases, but the good part is that this tumoral bleed is mostly intratumoral and few may rupture, and the most commonly this tumor at risk are the large size tumors, those having inflammatory variant of adenomas, and there is a progressive increase in the tumor size, those having hormonal use in last 6 months, and pregnancy. These are the risk factors for developing a intratumoral hemorrhage. So how to manage? The standard of treatment is transarterial embolization, reductive stabilization, and should be interval resection. This has lower surgical risk, less bloodless, less post-operative complications, and a shorter survival. So any hepatic adenoma, if a large tumor size, if have a bleed, we should not immediately go for emergent resection because it is more risky, even account for 5 to 10% of perioperative mortality that is considered to be a benign condition. So we prefer these patients to go for a transarterial embolization, stabilization of the bleed and patient conditions, and in interval of 4 to 6 weeks to go for a resection. However, about 7 to 80% of the tumors are mostly managed with simple analgesics, symptomatic controls, and after this symptomatic control, in absence of a transarterial embolization, these patients can be managed with a resection. So it needs to be individual case to case basis. Most commonly the conservative management. If no, then we should consider the transarterial embolization, and then we should go for the interval resection in this group of patients. Then if hepatic adenoma, when to suspect the malignant transformation. So you have to close look up this group of patients. The risk of transmission is up to 5%. The more common among the males, those having Fanconi's anemia, androgen treatment, those having beta-catenin mutations, or history showing little bit of dysplasia should be closely monitored, or they should be considered for the prior resections. Then these patients are difficult to diagnose, hence we need a biopsy because preoperative AP is normal. Imaging may be sometimes helpful, and if there is a malignant degeneration in the tumors. So that is showing that this chance of recurrence is less, chance of an aggressive malignant transformation is less. So these are the favorable findings. So with this, I want to suggest this hepatic adenoma management protocol that it consists first the male or female. So irrespective of the tumor size, male gender should be considered for the radical management because chance of having malignancy transformation and having beta-catenin mutation is more. If it's a female gender, if there is hormonal therapy, the first we need to stop it. Then we have to see for the lesions as single or multiple. If single lesion less than 5 centimeter, they should be on close supervisions. If they have complications with the hemorrhage, we should go for the embolization. And if after this the size is not shrink, we should go for a radical management, particularly the resections. Those having more than 5 centimeters, if it is having beta-catenin subtype or telangiectatic, they should be managed with resections. However, because of the benign pathology of HNF1 alpha, this can be weighted with surveillance to see for the tumor size progressively increasing size before considering for the resections. But among those having multiple lesions, we need to see the surveillance wise because they have a relatively transformation is less, and those having less than 5 centimeter lesions, definitely they should be closely followed up. So this is, dear friends, the algorithm which is applicable most of the liver adenoma for management. And here I want to say that MRI is the better modality for the characterization of this type of tumors. So just to come to our summary slides, SCC, fibrolamellar carcinoma, cholangiocarcinoma, FNS, hepatic cell adenomatosis, they have a typical of characteristic features for each all. So in that case, we need CT followed by MRI, but single modality, if I want to prefer the MRI, is the single modality which can helpful for the clear diagnosis in measured group of patients. However, these tumors, we need to think from the biliary aspect, from the hepatocyte aspects, and often we need a protocol-based treatment. So what I can suggest that first confirm your diagnosis. For this, we need the clinical input. MRI is the best modalities. FNA biopsy should be routinely recommended. And ISC, as we have discussed, for each type should be stained for the diagnosis. With this, we need a staging, PET CT or CT with MRI combinations can be helpful. Laparoscopic staging is needed in intrahepatic cholangiocarcinoma. However, it needs center-based protocols, and the treatment for all these is crucial for early detection. Resection is the standard of care, whereas other treatments should be considered case-to-case basis depending on the severity. So the clue and carry-home message is that liver mass, not typical for SCC, should need a quick multidisciplinary decisions for the further follow-up. Thank you.
Thank you, Dr. Ashok Choudhury, for enlightening us with your wisdom, because it's always challenging to classify a liver lesion. And thank you very much once again. So do we have all the speakers online? We can take the questions. We have one question from Professor Zaigham. What is the role of liquid liver biopsy in the diagnosis of HCC?
Actually, yeah. I think liquid biopsy means that we are looking for malignant cells in the blood. As we know that cells become detached and they are circulated in the blood. So if we are able to catch those cells, and that would be called liquid biopsy. Any other, Professor Galle, would you like to add something on?
Is Professor Zaigham listening to me?
Hello. Are you getting me? Hello.
Unmuted. Are the mics are unmuted? Please, everybody can check your mic if the mics are unmuted.
Hello.
Can you hear us, Amna?
Yeah, we can hear you, Dr. Adil. Were you
we have a
able to hear Dr. Zaigham Abbas?
No.
No? Okay, so I think the voice is not transmitting from here. IT team, can you please help? Dr. Adil, can you hear me now?
Yes, very loud
Okay.
and clear.
So maybe Dr. Zaigham, you can use this mic or that on kar.
So by liquid biopsy, we means that we are looking for tumor cells in some liquid media. So that media may be blood, and so we know that cells become detached from the tumor and they are circulated in the blood. So we can assess those cells in the blood, and that would be called liquid biopsy. Did you hear me?
Yeah.
Okay.
Thank you, Professor Zaigham. I have a question from Dr. Peter, if he's around. I can't see him.
Adil, Dr. Peter has to attend a acute medical emergency for a patient, so he just left. So maybe other speakers can answer, and then you can take the questions.
So the question was, what was the rationale to use immunotherapy in treatment of advanced HCC?
So anyone among the speakers can reply for this question. So the question is the indication or the role of immunotherapy in the management of HCC.
Actually, what I can understand is that there are different receptors, and these are receptors that are related with the programmed death of the cells. And then we are having other receptors that are the Ctla4 receptors, and this is cytotoxin T lymphocyte associated protein 4. So these are the different receptors that are involved, and what happens that there are certain substances that are released from the tumor, and these substances suppress the T lymphocyte response. So if you are able to block these receptors, then the immunity would get boost, and T cells would be able to eliminate the tumor cells, and they would help in programmed death of the tumor cells. So this is the rationale behind the immunotherapy. As Professor Galle mentioned, that first of these therapies are nivolumab, and nivolumab was one of the therapies, and later on Professor mentioned about the Imbrave 150, which is the atezolizumab and bevacizumab, and they have shown that there is a good response. The drug is given every 3 weeks, and there is a different side effect profile as compared to the sorafenib that we see, like this therapy, which is given every 3 weeks, is associated more with proteinuria, hypertension, and there may be a problem with variceal bleeding also. So when we prescribe this sort of systemic therapy, so we do the surveillance endoscopy, and we do the band ligation before, because there is a risk that is associated with this therapy, especially bevacizumab or Avastin. It has been previously shown that these patients may bleed if they are put on bevacizumab. So this is a combination that has been tried, and in this combination, atezolizumab is the checkpoint inhibitor or immune modulating drug along with bevacizumab.
Thank you, Professor Zaigham. I think this answers my question. I have another question for Professor Rosmawati, that as she was mentioning that in changing epidemiology of HCC, obesity is another risk factor which can lead to hepatocellular carcinoma without cirrhosis. So do we need to have some screening programs for morbidly obese patients?
Yes, I can do. I can't hear the question. I'm sorry, about obesity.
It was regarding HCC, changing epidemiology of HCC, that one of the risk factors is obesity now, recognized risk factor. So do we need to have some screening program for morbidly obese patient for the prevention of HCC?
Yes, I think that's what's lacking really. It's not just amongst those with obesity, but also amongst people with diabetes. So what has been advocated is now that you should be screening at least for fatty liver in all these patients with risk factors, or with the metabolic risk factors, for presence of fatty liver. And if you actually do find fatty liver, usually on ultrasound, rather than just on the liver function test abnormality, then you should also be assessing for the severity of the fibrosis using non-invasive tests. So the use of non-invasive tests is currently advocated in all patients diagnosed with fatty liver.
Thank you, Professor. Yes, we are already late, so before concluding, can we have some remarks from Dr. Hasib Haider Zia about this session?
Okay. Thank you very much, PSSLD, for letting us join. And it was a wonderful talk by all the speakers. I would still like to comment on Dr. Ashok's presentation. So he spoke about liver tumors other than HCCs, and it was an excellent talk. However, few points just to reiterate and emphasize is the role of multidisciplinary meetings in assessing liver tumors. I think the presence of radiologist, hepatologist, and especially the interventional radiologist is paramount because of varying features of all these liver tumors. And sometimes they have a scar, sometimes the scar is not that enhancing, etc., etc., the role of the liver biopsy as well. So trying to summarize the liver tumor part, which is mostly concerning a surgeon like me. In adenomas, I think he's given an excellent talk, but in adenomas, I think more than 5 centimeters remains an important cut point where you should consider resection. And in men, you should always resect. And if there is a classification of various types of adenomas, and if you get to biopsy them, it is the steatotic variety where you can observe for a while if it's less than 5 centimeters, but if it's unclassified, you need to proceed and resect it. Also, I have to emphasize the need of good radiology, where you can have the venous mapping as well as the structures in the liver whenever you're planning to resect. Fibrolamellar CA, as he said, the primary modality will remain a liver resection, which is the best option for these usually young individuals. Also, since it's less surgical, all these talks, so we have to also know when we are trying to resect these very large tumors, the role of portal vein embolization, etc. So these are the various things which I would like the audience to ponder upon, and generally excellent talks by all the speakers. Thank you very much.
Thank you, Dr. Hasib. And I think this concludes this session on liver tumor.
Adil, Dr. Kareem Kamruddin is over here. He was sharing the session. You just forgot him.
I
Dr.
think,
Kareem,
Dr. Amna, in the interest of time, I must also thank the organizers, number one, and then all the esteemed speakers, because they got the excellent talk, and we may proceed to the next session. Thank you.
So thank you very much. And so moving to the next session. The moderator of the next session is Dr. Mohammad Kamran. Dr. Mohammad Kamran, are you ready for the next session? So the next session is going to be very important, and this is one of the favorite symposium of PSSLD, which is a combination of different topics and covered during one symposium. We just lightly name it as Potpourri. So Dr. Kamran, over to you.